So good evening all. So we are from Jharkhand Ophthalmological Society. We are welcoming you all for our continued medical education program, the master class on pediatric cataract overview by none other than Dr. Lav Kochgawey. And for introduction of Dr. Lav Kochgawey, I invite Dr. B.P. Kashyap, our past president JHOS and management committee member from Jharkhand. So over to Dr. Kashyap. Bula.
Yeah, hi everybody.
In slide share karo.
We welcome Dr. Lav Kochgawey. With love, we call him Dr. Love. He's a founder and executive director of recently opened Netralaya at Calcutta and a highly accomplished senior consultant.
Love ka slide
specializing in pediatric ophthalmology, cataract, refractive surgery, and ocular trauma. Formerly assistant medical director of Shankar Nethralaya at Calcutta, and has made a significant contribution to ophthalmology in the region.
Dr. Lav ka slide.
Is a recipient of grand prize and APACRS Outstanding Contributors in Ophthalmology Award by ISCRS. He has multiple publications and awards to his name and has trained several pediatric ophthalmic fellows to advance and do advanced technology in the field. There are some chronic people in all the conferences. Dr. Lav Kochgawey is one of them. You go to any conference, you will see his face. So you are most welcome, Dr. Lav Kochgawey. Please go ahead.
Thank you, sir. And
welcome, Dr. Lav Kochgawey. So before you start, we have to introduce our office bearers and discussants. So today's our office bearers are Professor Rajnikant Sinha, he is the president. Dr. Sujay Samanta, he is the secretary JHOS. Myself, CSC JHOS, and Dr. Mala Verma, he is a prolific oculoplasty surgeon. He's our treasurer. And our today's discussants are, the star discussant of today is Dr. Parikshit Gokate. So I request Dr. Professor Sunil Kumar, Rio RIMS HOD and JHOS ARC chairman to introduce Dr. Parikshit Gokate. Lagao Parikshit Gokate.
Yeah. So good evening. So thank you, ma'am. So it's again my privilege to introduce Dr. Parikshit Gokte. So he is an accomplished ophthalmologist and surgeon specializing in pediatric eye care with extensive surgical experience spanning 33 countries. He holds MS Ophthalmology, DNB, FRCS Edinburgh, MSc, ex-IPS, FICO with over 400 scientific publications, numerous international presentations, and multiple academic distinctions. He is a leader in ophthalmology organization. He has served as a president of Maharashtra Ophthalmological Society and as secretary of the International Society of Geographic and Epidemiologic Ophthalmology. He has been editorial board member and section editor for Top Ophthalmology Journal and has held key roles in Global Ophthalmological Society. So welcome, Dr. Parikshit Gokte. Thank you.
So, stop sharing. We have, am I audible?
Yes.
madam.
Yes. So we have other star discussants also of today. So we have with us Professor Amit Raj. He is the HOD Patna AIMS and he has joined. So
thank you, ma'am.
Yeah. So, and we have another Dr. Amit Raj also from Patna AIMS. They are
Amit Kumar, ma'am. Amit Kumar is assistant professor.
We have Dr. Gyan Bhaskar. He is chairman scientific committee, Bihar Ophthalmological Society. He is in some function. He has joined from mobile. We have our ex-secretary, Dr. Vibhuti Bhushan, and our ex-secretary, Dr. S.K. Mitra, and our most chronic person of Jharkhand Ophthalmological Society, Dr. BP Kashyap. And he is the best discussant. So I have invited Dr. BP Kashyap to be with us. So welcome, Dr. Lav Kochgawey. You can share your slides.
Thank you, ma'am. Is it visible?
Yes, yes, visible.
So first of all, thank you so much for inviting me for this webinar. And we have 1 hour time total. So
yes, we have 1 hour time.
Okay, okay.
Because your thing will be beneficial for not only for ophthalmologists across Jharkhand, but also for PG students, everyone.
Okay, ma'am.
And everybody was eagerly waiting for your talk.
So I'll start with a very important topic, and especially because PGs are there among the audience and participants of this webinar. This is a very important question which all of us should answer.
Please mute yourself, Dr. Bharti.
Yes.
Please mute yourself.
Okay.
So
thank you. Please go ahead, Dr. Lal.
So who should be operating? And all of us, since pediatric cataract is a very attractive subject for all the ophthalmologists, so all of us tend to go towards operating pediatric cataract, and there is no harm in that. But before we decide to operate, everyone should go through this case, because if we have not trained ourselves well enough for pediatric cataract surgery, we may end with complications like this. This is a young child in which a single piece IOL was implanted in the sulcus. Half of the iris is missing due to surgical trauma. Some endothelial touch was there, and child presented to us with almost initial stages of corneal decompensation. So we had no option but to remove the IOL, and in which case we either you can bend the IOL into from the center and remove it with a larger incision of 3.5 millimeter, or cut the IOL and take it through a 3.2 millimeter incision. So in this case, initially we tried to bend the IOL and remove it. We were not successful. So then we cut it into 2 halves and removed it. But the lesson here is, especially for newcomers, no harm in doing pediatric cataract surgery, but at least the basic training, the basics of pediatric cataract surgery, we should be aware. We should have done a good number of adult cataract surgery so that tissue handling becomes more gentler. Because if this child lost his eye due to incompetence of the surgeon, and now will suffer for almost 70 to 80 years with one eye having very poor vision. So that is the implication of our actions, so that we should keep in mind. So from here, we'll go to the next. The initial investigations, what we do for anyone who has any question can ask in between only, because the presentation will be long and you may forget your question if it is there. So the investigation will be one of the most common causes for pediatric cataract in Indian scenario is intrauterine viral infection. So torch titer should be done, and many of the times what I have noticed, our concept is that rubella is the top contributor to it, but what we have found is cytomegalovirus being the most important reason for pediatric cataracts. Then there are other the less common ones, which are the metabolic reasons. Routine blood tests, chest X-ray should be done for fitness for surgery. In some cases, when you are operating very early, better to get a echocardiography also done, because if it is rubella associated, may be associated with a cardiac anomaly also. So the fitness for general anesthesia is very important. And sometimes you may have surprises if you have not worked up the patient quite well for anesthesia. Next important topic and mystery in pediatric cataract surgery, which is very different from adult cataract surgery, where we have to get ourselves trained, is the pediatric biometry. Most important challenge is that most of these children will not cooperate for biometry, either contact biometry or a optical biometer. So poor cooperation, poor fixation, sometimes it will be associated with nystagmus also. So that becomes a challenge. When we decide about the power of the IOL that has to be implanted, then myopic shift in children is a factor which we have to keep under consideration. Axial length keeps on elongating, so amount of undercorrection that we will do, that has to be taken into consideration. Effective IOL position, because we are doing anterior vitrectomy also, so the bag may fall back when we are implanting, and that effective change in IOL position sometimes leads to some surprises from what we have aimed at. So that also has to be kept under consideration. Another important consideration for IOL is if we leave the child with a very high hyperopia when we are operating them at a way, and if the child doesn't comply with spectacles, then post-op we may be inducing post-op amblyopia. So that is another factor that we have to consider when we are doing a biometry and deciding on the IOL power. Two must-haves for pediatric cataract surgery. This is one of the few cases where you have to keep a scan with you, and the machine what I am showing is not available now. So we have gone to another company which still manufactures a scan. And a handheld keratometer has to be kept, because if you are doing it in OT, then for the keratometry reading, the handheld keratometer should be available. Just a small video of how we do pediatric biometry in children. So this is, as you can notice, we have not put a speculum, because if you put a speculum, then the chances of corneal keratometry getting distorted and false reading coming is quite high. So keep the eyes lubricated. Don't put a speculum in the eye. Do a scan, and then you get and if it is a bilateral cataract, when we are operating the first eye, we do the biometry of both the eyes, so that second time we can skip this process. So to minimize errors, so I have already discussed, do not use speculum, to avoid problems related to corneal dryness, and measurement should be taken as soon as possible after induction of anesthesia, and BSS should be instilled frequently to make the corneal surface smooth. Which IOL formula to use? Again, important thing is that pediatric eye is not a miniaturized adult eye, because these eyes have a shorter axial length, steeper cornea, smaller AC depth, and error in axial length measurement affect the IOL calculation the most, because when you are doing an indentation biometry, then if you indent too much, 1 millimeter indentation may lead to 3.75 diopter error in children, while in adults it is around 2.5. About the formulas to be used, the most commonly what we use is either the SRK2 or SRKT or a Barrett formula. So target refraction in children, definitely we will aim for under correction to balance the myopic shift. And the points to consider is the age of the child, and if it aim for a little more hyperopia in a very small, if you are operating around 1.5 years of age and implanting a IOL. Status of the fellow eye is important. If it is a bilateral cataract, then decision becomes easier, and in case it is a unilateral cataract, then the refractive status of the other eye also has to be considered when we are implanting, when we are deciding the IOL power. Dense amblyopia, again, that what we have discussed, that lesser hyperopia will for better compliance with amblyopia therapy. Parents' refractive error has to be considered in predicting the future movement of the refractive error. limited range of IOL power effect, and many of these children will have a IOL power of 30 diopter, more than 30 diopters. So more than 30 diopters, the availability of lens is a bit difficult. So that is also one of the factors. Either you go for some companies have a higher range IOL, either you can use it or a custom made, or implant a 30 diopter only and correct the rest with spectacles. Bilateral cataract, early surgery is needed, but in bilateral cataract we can wait for maybe around 3 months, also 3.5 months, and both eye has to be operated within a short span of time, and this varies from surgeon to surgeon. I generally do both the eyes within 10 to 15 days. Unilateral cataract, myopic shift in the affected eye is more faster, and that also contributes to our decision in IOL implantation. Surgical techniques, the two most important techniques what you have to learn is the anterior capsulorhexis and posterior capsulorhexis. Anterior capsulorhexis can be done with, we have to use some kind of forceps, either a manual Utrata forceps or a microrhexis forceps or the Haldipurkar forceps. Vitrectorhexis is done in selected cases in which you have a fibrosed anterior capsule. So if you do a 23 gauge high speed vitrectomy, then that may suffice. Posterior capsulorhexis can be done either manually or vitrectorhexis, but many surgeons have now switched to vitrector for a posterior capsulorhexis after the IOL implantation. So these are some of the basics. Then now we'll go to the various surgeries that we perform. And this is a case, most common surgery which we perform when we are operating children less than 1 year of age, in which we just do a lensectomy. As you can see in this, with the cutter only, I have done an anterior capsulotomy. The anterior capsular rim is left for future IOL implantation, and then the whole of posterior capsule is removed with anterior vitrectomy. Now, another approach, what can be adopted in this is the pars plana route, in which we can go through the pars plana and do the same thing. And with high-speed cutters, things have become much more easier now. When I started, the maximum available in our machine was 800 cut rate. Now we have almost 4,000, 5,000 cut rate. Life has become more easier. Second is this is the most common procedure what we do in pediatric cataract, and which is the anterior capsulorhexis, lens aspiration, IOL implantation, posterior capsulorhexis, and then anterior vitrectomy with suturing of the main port up to 6 to 7 years of age. So as you can see, when we are doing anterior capsulorhexis, since the pediatric anterior capsules are more elastic, we have to, with the forceps, we have to grip and re-grip to complete, get a decent size rhexis. Otherwise, it tends to extend towards periphery. So the trick is with the forceps grip, 1 or 2 clock hours capsulorhexis is made, then re-grip, then again 1 or 2 clock hours, and repeat it 4 to 5 times so that you achieve a decent size rhexis. After that, cortical aspiration was done. IOL has been implanted in the bag. The main port is sutured, and then we go behind the lens, remove the posterior capsule of a size or a diameter of 4 to 4.5 millimeter, and do an anterior vitrectomy. So and a slight pilocarpine at the end, you are sure that there is no vitreous prolapse in the anterior chamber. But sometimes, this is one case which I wanted to highlight when you are doing posterior vitrectomy, because in this case, you will see that everything goes as by the book. We have done a good anterior capsulorhexis. The anterior capsulorhexis is complete. Cortical aspiration is done. And the bag is inflated. Then the IOL is implanted in the bag. Main port is sutured. Everything going on smoothly, just like a routine cataract surgery. And why I'm showing you that what all you can face when you are doing a pediatric cataract surgery when the posterior capsule is open and anterior vitrectomy has been done. So the posterior capsulorhexis also goes smoothly. Anterior vitrectomy has been done. Little bit blood oozing from the main port suturing what I have done, but that is not much of a botheration in these cases. And with the 23 gauge cutter, even the posterior capsulorhexis rim is smooth, and now you get a air bubble in between. So the visibility is less, and then to remove the air bubble, I start pushing viscoelastic and trying to remove it through the main port. And when you push harder, the posterior capsulorhexis has given way and the IOL is dropping in the vitreous cavity. So this is what you have to be careful about when we are doing a vitrector access for posterior capsulorhexis. So mostly I do a three-piece lens IOL implantation. So that was not a problem. We got hold of the one of the haptics, brought the lens again in the sulcus and implanted it in the sulcus. So the point to take home here is that when you are doing a vitrector access, don't push viscoelastic very aggressively. Otherwise, since it is not a round, secure posterior capsular access, it may give way. And eventually, this patient did well. So next topic comes is whether you are implanting a hydrophobic, hydrophilic, or a PMMA lens. So in this case, the IOL of choice now is definitely hydrophobic. Hydrophilic is definitely no, because long term it has been shown to have calcium deposits and lens opacities, and these children have to be with the IOL for almost 70 to 80 years. क्या हुआ? Then next comes whether we are implanting a aspheric or blue blocker lens, whether it is allowed or not. Yes, in children we can implant a aspheric lens, but with the fibrosis in the bag being very common in the children, the aspheric lens may decenter little bit and the aspherity may get lost, but that is not a contraindication for implantation of the aspheric lenses. Toric lenses we implant in older children and with a significantly higher astigmatism, maybe 1.5, 2 diopters or more. We do implant toric lenses, and that gives a better quality of vision, and the aberrations due to high cylindrical spectacle power is not there. Multifocal is definitely, I would say, no in children, because these eyes don't have 100% vision potential. So multifocal lenses work best with 100% vision potential. Single piece and multi-piece can be based on the choice of the surgeon. Now, this is another common scenario which we face. As you can see here, there is a wedge-shaped posterior capsular pre-existing defect in this child due to posterior lenticonus. So in this case, the important precaution what you will take is don't do any hydro procedure after anterior capsular access. After anterior capsular access, we straight away go ahead with cortical aspiration without hydro procedure, so that anterior vitreous face is not disturbed. Because if that gets disturbed before cortical aspiration, then it becomes messy, and then we may have to switch to cutter to aspirate the cortical matter rather than with the irrigation aspiration cannula. So here, after all the cortex is removed, the limited anterior vitrectomy is done without hydro procedure, so that the posterior capsule falls back, and then we inflate the bag and implant a three-piece IOL in the bag. And three-piece IOL works better. For why I select three-piece IOLs, that any time if you are not able to implant the IOL in the bag, we can easily switch to the sulcus placement. And after that, you can see then next category is the traumatic cataract. This forms a large portion of pediatric cataract practice, and is very common in rural and semi-urban scenario, in which children end up with cataract after injury, which may be either a blunt injury or a penetrating injury. So what here you see is a blunt injury, and which was left for some time and led to fibrosis of the anterior capsule. So whenever there is a fibrosis and when we are attempting a posterior capsulorhexis, there is a point beyond which it will not progress. So there is no point pulling the anterior capsule beyond that, because then it will extend to the periphery, and placement of IOL in the bag may not be possible. So we did the capsulorhexis till that point, and then used a cutter to trim the fibrous part and get a respectable opening in the anterior capsule. And what you can see here, we have almost a 4.5 to 5 millimeter opening in the anterior capsule, after which cortical aspiration can be done, and IOL can be placed in the bag.
Dr. Deepak, please mute yourself. Thank you. Thank you, Dr. Deepak.
And then here you can see the IOL is placed in the bag, posterior capsulorhexis is done, and very well centered. So if we apply, if we take different approaches for different cases of pediatric cataract, and what you see here is a gross subluxation and even a posterior subluxation of the bag. So in this case, probably there is no point preserving the bag and putting the IOL in the bag. So what we did, we went for a lensectomy, removed the whole of the lens, and left the child aphakic for future scleral fixated IOL. And in the meantime, the child can be kept on contact lens. And if they are not using contact lens, then spectacle with long hours of patching. But ideal would be contact lens in such cases. And while doing such lensectomy in such grossly subluxated lenses, it is always better to make an anterior opening in the bag. And if you are able to aspirate the cortex, aspirate it and then remove the rest of the capsular bag, as you can see in this case. So a neatly done and left aphakic generally does much better than a very badly done surgery with IOL implantation. And chances of visual recovery is better in such cases if they comply with contact lens. This is a traumatic cataract, and again, this is a penetrating injury. You can see entry point in the cornea, and the anterior capsule is also ruptured at one point. But many times you will have a fluffy cortical matter oozing out of the anterior capsular opening, but luckily in this case it was not there. So what we did with the existing opening, we went ahead and removed the cortical matter, inflated the bag, but in this opening, we will not be able to implant a IOL in the bag. So a relaxing cut was given in the fibrosed opening, after which the capsulorhexis was done. Same thing was done on the other side. Same thing was done on the other side, and now we have a respectable opening and IOL is placed in the bag. Similar, there is a different approach because this is another category which is a very common presentation in traumatic cataracts. And here you see there is a iridodialysis, the zonular dialysis is also there. So, and the rule is generally a broad rule is that if you have 3 to 4 clock hours of zonular dialysis or more, a scleral fixation device should be implanted. But in traumatic cataracts, many times these are non-progressive zonular dialysis. So on the table, we can decide whether the child will be, the bag will be stable with just CTR or needs a CTR plus a capsular fixation device also. So in this, as you can see, the CTR is implanted and gently dialed in the bag with IOL implanted in the bag. And it's quite well centered. Posterior capsulorhexis is also done using cutter because the posterior capsule was also fibrosed. So now you have us visual axis is clear, and this is the final outcome of the case. Now, if there is a similar situation with a larger iridodialysis, then you have to go ahead with iris repair as well. So both the cases are almost the same. So the initial steps I have not shown, but only the iris repair part I am showing in this, in which you can combine it with a traumatic cataract surgery. And this will help in future. The iris will not come in the visual axis and may give a better visual outcome in these children. So another case of traumatic cataract, what you see here is similar to in this also the anterior capsule is ruptured with a corneal wound, and it was a self-sealing corneal wound. So we decided to go ahead with cataract surgery, and cortical aspiration is done. After the whole process is complete, in this you see again the anterior capsular opening is small, so we have to use a cutter to enlarge the anterior capsular opening. And so most of the cases I'm showing is not repetitive. All these cases are presenting in a different manner. And in this case, what you see after IOL implantation, and we are able to place the lens in the back, but the corneal incision gave way in between. So one or two corneal suture had to be placed in this child, and which can be removed maybe 1.5 2 months later. So this child may not get a very useful vision, but some visual recovery will be there because the central portion of the cornea is almost opaque. So next comes the important discussion about what is the earliest age of IOL implantation. And what we have seen that more and more surgeons are now trending towards earlier IOL implantation, in which IOL is implanted in infancy also, or maybe around 1.5 years, but the consensus is 2 years of age. So for starters, people who are starting pediatric cataract surgery, it is always better to implant IOL at 2 years of age and older. And then as you gain confidence and case by case basis, you can decide later on. Important factors there. The target refraction we have already covered, and infants in infants, if a child not using aphakic spectacles, then the effect will be as good as no surgery or contact lens if they are not using. In those cases, especially unilateral cataract, earlier IOL implantation can be done. Or another factor is if you have a corneal diameter more than 9 millimeter or axial length more than 17 millimeter, then we can think of implanting a IOL in earlier age group, but the chances of resurgery for visual axis opacification is higher in such cases. So when you have left these smaller children's aphakic, then at some age we will have to go for a secondary IOL implantation, and this is the surgery which is demonstrating that. And what I had told earlier, that anterior capsular rim has to be left. So this is what commonly happens. From the anterior capsule, you have posterior synechia on the anterior capsular rim. So we have to gently sweep a spatula and release the synechia before implanting the IOL in the sulcus. And if the rhexis is big enough and it is a optic capture also can be attempted in these cases. So this is how we do a secondary IOL implantation, and generally I do it immediately after 2 years of age. So because the children holding such heavy spectacles is burdensome for the children, so it's always better to give them IOL immediately after 2 years of age, if the axial length and corneal diameter is permitting. So next comes the subluxated lens. Again, this is probably you should master last when you are doing a pediatric cataract surgery. First is lensectomy, routine pediatric cataracts, then comes the traumatic cataracts, and then finally comes the subluxated lenses. So in subluxated lenses, there are two. I am talking about the progressive subluxations due to Marfan syndrome and others. And in this, these are generally non-traumatic and progressive, leads to high myopia and high astigmatism, and visual acuity tends to start dropping when the lens margin starts coming into the pupillary area. So we have to take a decision as to when to operate these patients and what are the surgical options. So I would say if you are preserving the bag, there are 2, 3 options. One is smaller segments which can be implanted with a capsular tension ring or a Cioni ring, or if you are doing a scleral fixated IOL, then conventional with sutures, either a ninoprolene or Gore-Tex, or a glued IOL. But one important point is that these surgeries are done in slightly older children, maybe 8 years and beyond, so that the sulcus is well formed, the ciliary processes are well formed, and there is space for scleral fixation. So first option I would show here is a lens aspiration with CTR and MH segment. And mostly in subluxated lenses, I have tried almost every procedure, and at the end of this, I will tell you what is the after trying everything, what is my conclusion as to which is the best procedure in such progressive diseases. So if you are trying to preserve the bag, then initial capsular access is done, and after which the capsular hooks are applied to pull the lens in the center. And after pulling the lens, then here you see that we have implanted a CTR, and IOL is placed in the bag. So whole procedure will take almost 45 minutes. What you are seeing here is a grossly edited video at a higher speed. So, and after removing the capsular hooks here, I see that there is a the anterior capsular axis is extremely decentered. So we made a relaxing cut in the anterior capsular axis and made it of a decent size, after which a scleral pocket is made and a 9-0 proline suture is being used to implant a Ahmad segment. So the segment has to be implanted on the subluxated portion of the lens. And using a railroad technique, the Ahmad segment is pulled with taking care that the eyelet is anterior to the anterior capsular axis margin, And here you titrate it and make it slightly tighter so that eventually the lens doesn't subluxate to the other side. Second option is a Sioni ring, in which here you will see that this is almost more than 180 degrees subluxation, in which the same process is repeated. And initial capsular access is done, and while before completing the capsular access, we gently pull the lens on one side, and so that the whole of the bag is visible. And then the Sioni ring is sutured with using a ninoprolene. The problem with Sioni ring is it is inserting it into a smaller bag. So in this case, you see that we were able to and this was my first case using a Sioni ring. And it went so smoothly that I was very thrilled that it is much easier compared to a Ahmed segment. But subsequent cases, I felt that it is not so, that even with Sioni rings, many times you may face difficulty while inserting the Sioni ring in the bag. And these are cases almost 10, 15 years back, and they are still following up with me. And till now, of all the bag preservation surgeries, what I have done, only one patient has developed retinal detachment. And all of them are maintaining almost 612, 6:9 vision, and still the lens is holding on. The other side has not given way, but whenever you see the patient on the slit lamp, you are not very comfortable. Always you fear that the other side may give way, and or the phimosis is so severe that we always fear that it may have a visual axis opacification may occur. And many times we have used YAG to give relaxing cuts on the capsular axis margin. Third option, here you here what we see that capsular axis has been done, and in this, the other eye we had managed with only a CTR, so I was not prepared with a scleral fixation device. So in that case, what I did was after implanting the CTR, and this was a slightly older child, so CTR is done, implanted, IOL is placed in the bag, and posterior capsular axis also has been done using a cutter. But as soon as we remove the capsular hooks, we see that the lens is decentered. So what we did was that we punctured the bag using the CTR as the hinge, and we fixed the CTR to the sclera and worked out quite well. So this is another method what we can use for scleral fixation in subluxated lenses. Few difficult situations of subluxated lens. I would show that this is what I was mentioning. After the first Sioni ring, I was very confident that the Sioni ring is much easier. So I started this and till capsular axis, it went on smoothly, pulling the lens towards the center and completed the capsular axis. After completing that, one difference what I did that time, I had implanted the Sioni before cortical aspiration. Here I did a cortical aspiration first and then decided to implant the Sioni. And that is where I got stuck. The lens, the Sioni would not go into the bag, and in the first attempt, whole of the Sioni came out in the sulcus. And then pushing it inside the bag was a big challenge. Tried for 15-20 minutes, and then finally, before before deciding that I will remove it, gave it a firm posterior push and dialed it inside the bag, and fortunately this time it went in. So and we could complete the procedure. So this is one difficult case. Second is this is another, this is not that difficult, but it is a atypical subluxation. Here you can see that lens is subluxated on both sides, and with almost 2 clock hour fixation on one edge, and other edge it is 4 to 5 clock hour fixation. So overall, you are getting almost 5 clock hour one side and 2 clock hours, 7 clock hours it's fixated. So we decided to not to have any scleral fixation device in this. The capsular axis has been completed, after which cortical aspiration is done. And here you have to be careful so that you don't pull the zonules too much and extend the dialysis. So after good hydro procedure, the cortex is aspirated. After CTR implantation, the IOL is placed in the bag. And as you can see, it's quite well centered and doesn't need any 0.01 fixation device in this. This is probably a surprising element was there in this. And this is a traumatic subluxation in which the anterior capsule is fibrous. So vitrector was used for the anterior capsular axis. And when we are we are getting almost 4.5 millimeter sized anterior capsular axis. Cortical aspiration is done. And here you see the subluxation from the other side also appears. So this is a traumatic case in which it is subluxated on both sides and with being fixated by almost 3 clock hours on the edges on the two poles. So here also I decided to, after the anterior capsular axis and putting a CTR in this, it is a bit risky because the anterior capsular axis is done by cutter. So any weak point, and while we are pushing the CTR, it may give way and then we have lost the bag. But since some fibrosis was there in the anterior capsular axis, I decided to try a CTR implantation, but the CTR would not go. And kept on trying and it's not going. It's not progressing because the bag is so unstable. So this is the first time I decided to do a capsule, use a micro forceps to push the CTR in the bag, and it worked wonderfully well. So this is one of the techniques of implanting a CTR. If it is not moving forward, we can use a micro forceps to implant it in the bag, and after which the bag was again inflated. Yes, sure. After which the bag was inflated and the capsular axis opening was enlarged. The anterior capsular axis was enlarged. And the length implanted in the bag. So eventually you get a very well-centered IOL in the bag. So these are some of the cases, and this I will skip because lensectomy I've already demonstrated in one of the traumatic subluxations. So this is another thing. And if the IOL bag complex in a progressive disease gives way from the other side, what is the solution to that? So here, what we demonstrate what we can do in such cases, because there are many critics of preservation of the bag, and the their point is that when it is a progressive disease and it will give way from the other side, then when we are fixing from one side, there is no point in doing that. But this is the solution to that. If it gives way from the other side, just since the whole of the bag is fibrosed, at the haptic optic junction, we can pierce the bag and fix the haptic itself to the sclera. And after this, the bag will become very stable, and it is hardly a 10-minute procedure. So in this case, you can see that we have pierced the bag and bring it out. And using the railroad technique from the other side, one goes posterior to the bag, and when we bring the same suture out on the scleral side, it comes anterior to the bag. And once this is done, and we fix it and bring it to the. And photon is definitely here. You can see it's almost whole of the lens is subluxated. So better to do a lensectomy and scleral fixated IOL. But care has to be taken that all these are older children. Don't do it in a very young child, because then the chances of complication is much higher. So in pediatric cataract, the follow-up is initially done every 3 months. And what we look for is refraction, the change in refractive error, because the pediatric cataracts, the myopic shift is faster, and especially if it is a unilateral cataract. We look for visual axis opacity and intraocular pressure, and we reinforce patching in every visit, because parents tend to become complacent and they give up patching in between. So call these children more frequently and reinforce the need for patching. I think that is the end of it, and it's open for discussion now.
Dr. Love, it was you really had so many cases to discuss. I think one session should be only on how to manage all these, subluxated lenses and all, and how to stabilize and how to stabilize the bag. That should be a separate lecture of yours. And how did you could you just go through how you managed to, with the railroad technique, you made a puncture through the rim.
Oh, the bag fixation you're asking?
Yes. With the railroad technique, how did you do that?
So the lens is already in the bag. So what we did first, through the sclera, we'll go pierce the bag from posterior and then come out through the main port. And then the second suture, when we guide it from anterior to the same needle is brought back to the sclera, anterior to the capsular bag. So it's like this. If this is a haptic, your suture is going like this and pulling the lens towards the sclera again.
Excellent presentation, Dr. Love, and you have shown a large number of cases, especially complicated cases. Where IOL power is more than 30, especially J&J multi-piece lens comes up to 30. So in that cases, what you do, or what you prefer?
I generally leave it at 30 only and replace the rest with a spectacle or contact lens. But many surgeons, the Alcon single piece is available at more than 30. The single pieces lenses are available at. The voice is not coming.
So
2.5. A word of caution is not everybody should try these surgeries, because these surgeries are not very easy. Even the lensectomy, while doing lensectomy, there is a chance of drop down. If you're putting a CTR, the CTR might rupture the capsular bag. You have to get training, you have to do practice, and then probably you'll be as expert as Dr. Lav Kochgawey. A fantastic series, Dr. Love.
Thank you,
And
sir.
the especially the subluxated lenses. Sometimes it works, sometimes it doesn't work, sometimes it comes to the center, sometimes it doesn't. So if the subluxation is more than a half, I would rather prefer to go for a lensectomy and SFI, which is
That is my preferred choice nowadays. That nowadays I don't preserve the bag. Earlier I was very passionate that bag has to be preserved, but over a period of time I realized there's no point preserving the bag. Remove the lens and do a neat scleral fixated IOL.
First class, very nice, very nice.
So if I can add, so it was a very nice talk. I'm Dr. Siddharth. I'm assistant professor in Guru Nanak Eye Center. Sir, what is your take on retropupillary fixated iris claw lenses for
I've not.
subluxing?
By many centers it is being used and it is working very well. Even in Europe, that is one of the preferred choice of IOL implantation in subluxation. I personally don't have experience with that.
Sometimes these are very high myopic children with, axial lens somewhere around 29, 30. And, making scleral flaps and, doing scleral fixated lenses can be challenging. That's why I just wanted to have some.
My only concern with that is
So the
the
iris,
pupillary dilatation. How the I mean, since I've not used, I'm not aware. Does the pupil dilate fully after that retrofixation?
yes, sir,
Because
it does dilate and it generally does not cause a problem, sir.
And sir, you had mentioned about the torch titers to be done routinely. Does it alter the management in any way if
that
we
is
do it?
more for general anesthesia. If the torch titer is positive, then next step will if it is positive for rubella and other thing, then we will prefer to have a echocardiogram also. But I don't do torch titer regularly in all patients because many of these patients are poor; they are not able to afford. So
Yeah.
straight away I go for echo and do the surgery.
Dr.
Sir,
Siddharth,
one more
please
question.
introduce yourself.
Ma'am, I'm assistant professor in Guru Nanak Eye Center in Maulana Azad Medical College, ma'am.
अच्छा अच्छा,
Currently
तो तुम्हें लिंक कहाँ
looking
से
up.
मिला?
Ma'am, Dr. Subhash had shared because
Okay.
I'm looking after pediatric ophthalmology.
Very nice, very nice. You are most welcome.
Yeah, thank you. One more thing, sir. What is your preferred suture for these cases? Like all of them were nylon, I saw. Are you using Vicryl sutures also in these cases?
Vicryl for scleral fixation.
Oh, no, for routine, main
Routine,
wound
no,
suturing.
Vicryl, there is a reason why I don't use. See, Vicryl gets absorbed, but by the time it degrades, it causes inflammation on the edges of the suture, and sometimes the suture becomes loose and mucus accumulates there. That is why I gave up Vicryl. Now what I do, I use nylon, and exactly at 1 month, I just give a short GA and remove the nylon sutures. That also, I don't wait for the suture to become loose and remove it because then the same problem occurs with nylon also. So at 1 month, I remove the nylon sutures.
The one last question. I have a lot of questions, but one last question. What is
so
your
Dr. Siddharth, I will, if I may add, is I do use Vicryl and 10-0 Vicryl is good because if it's a very small child, say 8-week-old child or a 14-week-old child, then giving multiple GAs for evaluation under anesthesia sometimes can also be a challenge in medical colleges because the children come from far, the follow-ups sometimes are not done. So one good advantage with Vicryl is Vicryl degrades, so it does not, you don't have to go back and remove it like you do with nylon.
Okay, so one more thing. What about the standard K which we use for IOL power calculation? All children undergo EUA preoperatively or on table in the same sitting, or do you use standard K also?
Same sitting on the table I do. I don't use standard K. Same sitting on table, we do a biometry first, then put some Septidine eye drops, and then drape and do the surgery.
Yeah, and sometimes you are unable to get the A scan done, the biometry, the ultrasound doesn't work. It doesn't take the axial length. In such cases, we go for after making the patient a fake, you go for refraction and then adjust the IL power.
Thank you for your input, sir.
And Dr. Love,
Yes, sir.
you believe me or not? People laugh at me. You believe or not? I don't put stitches in these pediatric cataracts. I never had any collapse of anterior chamber, but I fill the anterior chamber with air.
Yeah,
And
yeah.
I I have never, got the collapsed anterior chamber or something. But then
Sir, as
people say
pediatric
that,
ophthalmologists, if we do, our colleagues will kill us. They will. So I've never tried also.
yeah. But then I've been telling people that, yeah, I don't, all my junior colleagues say, even my son says, Dad, give us stitch. I said, look at this patient next day tomorrow. And there is no foreign body sensation. There is no hassle of removing the lenses. There is no stitches. There is no hassle of, tugging the knot inside the cornea. And when we do that, it becomes loose. So there is no hassle. So it's so nice. I mean, probably, and after some time, somebody might, say, yes, I have been Dr. Kashyap.
and probably you are making a slightly longer
hygiene is
turn.
not proper.
Huh?
So basically, one should apply suture at least in main port. Side port,
Why?
I would suggest less than 2 years one should apply suture in side port, but main port one should apply because in most of the patients from rural background, hygiene is not proper. They will rub the eye and collapse of chamber very high.
That is what I'm talking. So I don't put stitches. I insert air in the anterior chamber and never had this problem. If the problem has to occur, it is during the operation and I give one stitch. Otherwise, in 99% of cases, I do not put stitches. What you are talking is very logical. But then I don't put it and put this air. It works very well. So you may try in some cases. We will not tell you that you have tried, but you try in such cases. If you feel good, go ahead. Yeah.
One advantage is that if you're not putting the suture, you don't have to deal with the uprolling of the eye after the anesthesia has fallen short before the surgery is over.
Yeah, you are right. And then a citizen hurry.
Yes, and then it becomes difficult to put the suture there.
Yeah.
Dr. Love, what will you do in a unilateral cataract under 2 years? Difficult to make them wear the fake glasses.
That is one category in which I err more towards IOL implantation if the axial
Dr.
length
Lav,
and corneal diameter.
I want to know who is speaking.
I'm Dr. Anita.
Okay, Anita. Welcome. She's our one of the discussant from Patna. IGIMS, but no, IGIMS, right?
RIU, ma'am is from RIU.
Yeah.
Oh, she's from, okay, she is my WAS team. We used to be together in WAS. Okay, go ahead, Dr. Anita.
So in those cases, if the axial length is more than 18 millimeter and the corneal diameter is more than 9 millimeter or more, then it is advisable to implant IOL rather than leaving them FAK. One of my case in which I got an award in APCRS, that child is now 11-12 year old. Post ROP needle prick. In ROP, someone had given a intravital injection, had a needle prick on the posterior capsule and developed cataract. That child I implanted IOL at 3 months of age and is doing now having 6/6 vision. Though the refractive error is high, but having 6/6 vision.
Have you ever done a PI, or do you ever feel the need for a PI in any case?
No.
So, Dr. Love, have you seen the era of needling?
No, sir, I have not seen.
You have not seen the era of needling?
No.
Okay.
I have, sir.
You have seen?
You have? Good. So somebody in a conference, somebody was talking that, oh my God, if you leave some amount of cortical matter in a case of pediatric cat, it's going to give you very, very hard, very intense reaction. I'm really talking. We have done needling and then, cleared the things and then it gradually absorbs and it becomes all right. The patient is happy. So needling,
we have 7-year results from the Miraj pediatric cataract study, a 7-year follow-up of pediatric cataract. And it is for cataract surgeries done between 2000 to 2005. So there the worst was for needling cases, those which were done earlier before we started doing vitrectomy. So it is good where nothing is available, but otherwise, of course,
it was good. It was good. It was
present time, no, absolutely no.
So one more point, can I raise? One more point? Sir, how about the immediate sequential bilateral cataract surgery in the same sitting? Though Dr. Parikshit sir has said he's doing routinely in less than 3 years. So do you recommend doing immediate sequential surgery in the same sitting?
I've done once in Orbis plane. In Orbis, they had in 2004-5 in Western countries they are doing simultaneous bilateral. So what they did was one surgeon operated one eye, then everything was changed. Then I operated the second eye. Like that it was done. But in that scenario, I'm not very confident.
So like we have done about 15 in last 1.5 year, like 15, though they were okay. And I was also reviewing the literature for one talk because, what I was told by, the senior pediatric ophthalmologist that there should be institutional protocols because if a child lands up into endophthalmitis, and so I just want to know the take of the seniors that what do they say? Matlab, should we do it or not do it? Like how do they?
Even one child having bilateral end-off and losing his vision, is it worth in our whole career? So
I have also never done simultaneous, even adult cataract, basically.
Yes, sir.
A single case can spoil your career.
Sir, but when we do one and few days later we again give GA to a child who is say 1 year old, then the risk of life and the risk of anesthesia also has to be weighed against the risk of endophthalmitis. So if everything is changed, I mean, in Paediatric Medical College, it is generally antibiotics that we use. So, and we measure all the reports, even the reports, and it's all done under single anesthesia.
Love, I do a bilateral if I have to make the patients aphakic. I mean, less than a year, I do a lensectomy. I don't
bilateral in the same sitting.
Yeah, aphakia. But then I have to put the implant. I'll do after a little while, at least 1.5 months or so, at least.
I space it about 1 week apart. 1 week, 10 days.
Yeah, that's good. That's good.
Thank you.
See, these are questions in which we cannot have a definite answer. Everyone has a point and has a very strong point. So it's best for all of us to know these points and take a decision for ourselves as to what we want to do. There is no definite guideline for this.
Right.
Any experience of reverse optic capture without anterior vitrectomy?
Because I don't do manual posterior capsulorhexis, no. So in vitrector rhexis,
there is always chance of basically peripheral extension.
Reverse optic capture is very risky. It's very risky.
There are few published studies, especially by Jagat Ram sir. He has done
Dr. Jagat Ram, Dr. Varsavada, all of them. And their logic is that anterior vitrectomy can be avoided if you are doing reverse optic.
I am doing a thesis on my PG student. Basically, we are doing RCT on 4 to 8 of 4 to 8. I am doing PCC with entire vitrectomy, and in another group, we are implanting IOL. So to see what is the optimal age where one should leave the PC. So probably after 6 months, I will be able to tell what are my
I do
results.
posterior capsulorhexis even in 12 year, 13 year, whatever pediatric cataract I'm doing, I do posterior capsulorhexis and anti-vitrectomy.
Probably I will get answer. So I will share result after 6 months.
When we do this posterior capsulorhexis with the vitrector, sometimes it extends when you're putting the lens. Has anybody else also seen this happen? The moment you put the lens in the back, the posterior capsulorhexis, if it's been done by the vitrector, it extends.
No, but that you should do after, if you are doing with vitrector, you should do after IOL implantation, not before.
Yes.
Yeah.
Yes. That is a point. Your take, Siddharth Madan?
Yeah, ma'am, I agree. I had actually put one comment regarding this when sir was showing his video when he had put a viscoelastic and the IOL was tilting. What, sir, even this is I have also felt that once we do try to remove a dispersive viscoelastic after we have put IOL and we have done a vitrector associated capsulorhexis, PCC, that time it can give way. So then I try to use a cohesive viscoelastic so that, it can come out as a bulk. That is one thing. And what I was thinking that should we put the suture later on after we have removed the visco and, and then try to suture because
in that case, what had happened?
Yeah.
In that case, what had happened that due to the air bubble, I was pushing it bit more aggressively so that the air bubble presses out. But that is why it gave way. Otherwise, that is the only case in which after vitrector access, they gave way.
अच्छे से रख देना चार्ज में लगा ये फाइल ले जाओ
Capsulorhexis, so
yeah, it is a weaker capsulorhexis. Yes.
Yeah. So I think today we had enough discussion and we should wind up. What do you say?
Yes.
Yeah. Time for dinner.
We took more than 1 hour in this.
Yes. It is a nice Bihar and Jharkhand session. Lav is also from Bihar. I never knew that. Recently, I came to know that he's from Bihar. Lav Kochgawey. So thank you very much, all of you, for contributing scientifically in a great way for Jharkhand Ophthalmological Society. Thank you, Dr.
everybody,
Lav.
and
Thank
good
you,
night.
Dr. Parikshit.
Thank you for the invite.
You also took time from your busy schedule. Dr. Parikshit is also contesting for IJO.
Dr. Parikshit.
Batao, Dr. Parikshit?
Yes, ma'am. Contesting for the editor, Indian Journal of Ophthalmology.
Dr. Lav, he needs support.
I know, ma'am.
Dr. Amit Raj, he's a Patna AIMS HOD. Actually, Dr. Parikshit Gokade, I know from my LDP days. He is my age group.
LDP course.
And LDP first batch, we were myself, Prashant Bavankule, Parikshit Gokade. We were the LDP first batch, 2006-2008. So we grew together, and he is such a masterpiece. So suddenly I today called him and asked him, what is your specialty? He said, I am a pediatric ophthalmologist and I do both squint and pediatric cataract, everything, pediatric ophthalmology. So I said, it would be very nice. And then I changed the flyer and added his name. It is really very nice of you that you joined us. Thank you.
Sir, Parikshit sir, how do you pronounce your surname?
It is Gogte.
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 Gogte. Parikshit Gogte. Are you a Marathi?
Sir, Marathi.
Okay, actually, my daughter-in-law is also a Marathi. Her name is Nidhi Gadkar. Nidhi Gajendra Gadkar. She is a Marathi Brahmin.
Gajendra Gadkar.
Gajendra Gadkar. Yes.
Gajendra.
So you are Gogte.
Gajendra Gadkar तो Chief Justice of India थे एक.
अच्छा. Okay. Thank you so much. Thank you, love. Boss Nikala.
Thank you. Congratulations to us.
He's doing very good also.
Thank you.
Okay, Dr. Parikshit, Dr. Lav, Dr. Amit Raj. Amit Raj had a very big, very massive OT. He has just come back.
Yeah, busy OT.
Very busy day. Okay. Thank you all. Bye.
Bye.
Thank you, ma'am. Thank you.
Anita. Anita.
Yes, I'm here.
Yeah. Thank you so much. Anita was also very busy today. She had some family function. Some big responsibility. Yes. She had personal thing.
Yes.
But she joined and contributed a lot as a discussant. Thank you, Anita. Thank you.
Thank you, ma'am. Thank you, Dr. Love.
Yeah.